focused on preschool age children, and I will just ask Alex to go to the next slide. So just to give a bit of context from a child health and wellbeing network, the network covers the whole of the North East and North Cumbria footprint. We're a part of the ICB's function, and we are very much focused on prevention and addressing inequalities. And I don't think I need to labour the challenges that we have as a region. You can see there some of the stats, and the Healthier Together website is very much around trying to drive work and contribute to supporting those reducing the high rates of A&E attendances, and particularly in our 0 to 4-year-olds. As we know, actually we have the highest rates in the country of in this age group, and actually, you know, the pressures that brings, but also how we support parents to address parental anxiety when their children's unwell. We also have high rates of asthma admissions, and actually, you know, there's a lot of information on Healthier Together that supports the management of asthma, and obviously giving parents that information. So there's a lot of challenges that we know around poverty, and obviously a lot of our approaches that we do as a network is around that collaboration and trying to work with our VCSE and education settings, and that's some of the things we've done with the Healthier Together Champions programme, is really about working with those organisations to reach our most underserved communities and give those the tools and the resources to be able to share Healthier Together there. If you'd like to move to the next slide. The network is very much, it's the vision was established in 2018, and it was brought together by professionals and children, young people and families across the region. It was very much that we believe all children and young people should be given the opportunity to flourish and reach their potential. And you can see there that's our priority wheel, and there's a number of priorities around there, around mental health, poverty, inequalities and access. And you can see in the like blue purple colour, family support. That was actually as a result of COVID. We went back out to families and children and young people and the system and professionals, and it was very much that family support was felt to be a priority. And I guess a lot of you on here will be kind of supporting families in that way in the work that you do. And what the system wanted us to do was share good practice, drive work forward and connect us in expert groups. And a lot of the things we do here, obviously this session's been led by our clinical lead, so we have clinical leads, we have inequalities advisors and different advisors input into the work that we do. Next slide, Alex. This is just giving you some of the breadth and reach that we do through our communication, so our lunch and learns and huddles and sharing the learning across the region. And you can join the network, and when you get the slides, there's a link if you're not already signed up. And the last slide, please, Alex. So just to give you a bit of an overview of the work that we do lead on, the Children and Young People's Transformation Programme, our integration programme pilot, which is due to come to an end, and the complications of excess weight pilots across our region. So there's a lot of work around service improvement, system work, and improving that in relation to asthma, epilepsy, transitions and diabetes. You can see there as well, we do a lot of work around tackling inequalities in children, and that's things like youth mental health first aid work, and we've done a lot of work with Children's North East, working on the poverty proofing agenda and our South Tees Arts Initiative, as well as the things that we're doing around Core 20+5. So I'm going to stop there and I'm going to hand over to Alex, and she will go on with the session. Thank you.
Thanks, Laura. So as Laura said, I'm Alex Battersby. I'm one of the clinical leads for Healthier Together North East North Cumbria, and I'm a consultant paediatrician at the Children's Hospital. My plan for today is to talk about some of the common conditions and presentations that we see in preschool children, and to think a bit about those in both the acute and the outpatient setting. To think about what those red flags are for those presentations, and also think about when to refer, and also to show you hopefully how Healthier Together can help you with these decisions and share information with parents. Some of you may have been to the presentation that I gave last week, which was about the under ones. There will be a little bit of overlap, but hopefully not too much, so hopefully it will still be useful. So the conditions that I'm hoping to cover are a bit about acute wheeze, as Laura has alluded to, a bit about diarrhea and vomiting, and then thinking about the more chronic presentations. These are really the ones that we see the most referrals for with regards to outpatients. So I thought it would be helpful just to go through some of those. So thinking about cough and wheeze, lymphadenopathy, tummy pain, constipation, UTI, and sleep. For those of you who aren't yet familiar with the Healthier Together website, this is what the homepage looks like here. And I will be showing you some of the pathways and some of the snapshots from the website throughout this presentation. We use a traffic light system, and this works both for the professional pathways, which shows you when you need to refer, and also for the parent information. The pages, as you start to get used to them and look at them, you'll see that they all look very similar, and we hope that what this does is that it provides some reassurance to parents and that they'll get used to using them and they'll understand how that traffic light system works. The professional pages and the parent pages are open to both groups. So the parents, if they really want to, can look at the professional pathways. And we think that that's one of the really important things about the website is this transparency. So nothing is really hidden. And hopefully they correlate with each other so that everyone's looking at the same kind of information.
Tell them the sources anyway. When you see, no, we can't.
There's someone who's not muted. So could everyone just make sure that they are muted so that we don't hear snippets of conversations? Thank you. The professional resources are in a different section, and you'll see them on the website that they cover both referral pathways. As Laura said, any of our webinars and presentations are usually uploaded there, and there are resources for different groups of people. So the first thing I was going to think about is viral-induced wheeze. It seems to have been a very long winter in the health service, and I think sometimes the winter never stops, and so we continue to see those respiratory illnesses throughout the whole year, and particularly coming into hay fever, sometimes that can really present as wheeze as well. We know that viral-induced wheeze is a really common presentation in preschool children, so in the age group that we're thinking about. And some of those children will have a single episode, but for some of those children, they may have multiple episodes or recurrent episodes. Some of those children will have features of atopy, so that will be a personal history of things like hay fever and eczema. And it's really important that actually you ask about these things, because sometimes parents may not have noticed, or it may only just be becoming prevalent. And so it's always worth thinking about those things. Some of these children will also have interval symptoms when you ask about it, and for those children it can be a much more similar presentation to one of asthma. So particularly in the children who are approaching school age, thinking about asking about interval symptoms can also be a really important part. So the acute management of viral-induced wheeze looks very similar in some ways to the treatment of asthma, which we're probably very familiar with. We always recommend a trial of salbutamol. Now, if you came to the presentation last week, you'll know that for children with bronchiolitis, we know that salbutamol has no effect, and there can be a really challenging age around the age of sort of 12 to 18 months where they are sometimes behaving more like a bronchiolitis and will not have a response to salbutamol. So in these situations, it's perfectly reasonable for those children where there's clinical uncertainty to give them a trial of salbutamol. Salbutamol should always be given via a spacer. We've got a lot of information on the website about how to give a spacer and about using technique. And it's so important that we get into these habits early that we should use a spacer from the start. The benefit of giving a trial of salbutamol, and this is something that we do quite a lot in the hospital setting, but it would not be unreasonable to do in a community setting, is to see how they respond with regards to work of breathing. So the treatment is not to look for absence of wheeze, but it's to look for response to how hard they're working with their breathing and to see whether or not there's been an objective response. If there is a response, then we do recommend continuing the salbutamol, and on Beat Asthma, which is linked to from our Healthier Together page, there are very good wheeze management plans. The use of steroids is an important one to think about, because actually some children get multiple, and we'll come on to this in a bit later, get multiple episodes of respiratory tract infection, some of which they'll receive salbutamol for and some of which they won't. Children of this preschool age shouldn't be given steroids at the first sign of wheeze, and actually it's really important that we think about this, because steroids are not without harm, they don't taste very nice, and in children who have a single episode of viral-induced wheeze, they are not indicated for the majority of patients. They should be, that said, they should be considered in children who have a severe episode, but those children should be referred to hospital if they are meeting the criteria for a moderate or severe episode. They should be presenting to hospital. So generally in the community, the role for steroids is very, very limited in this cohort. Wheeze management plans are available, as I said, from Beat Asthma, and we've gone away from using the 10 puffs of salbutamol every 4 hours, irrespective of whether or not a child need it, into a much more need-based plan. And these plans can be downloaded for parents and either printed or SMS text or directed towards via the website. The other thing is that never miss an opportunity to give some smoking cessation advice. Although smoking may be less common than a few years ago, it's still very much a part of our public health initiative and part of an important part of managing respiratory conditions in children. Hopefully no preschool children are smoking or vaping themselves, but advice should certainly be given to family members, and support can be offered through the NHS websites as well. But then what? And this is a question that we're often faced with, and particularly when children are getting recurrent episodes of wheeze. It's important to think about what constitutes a kind of a red flag. And what I'm going to think about is a bit about cough in general. So the red flags for children who present with recurrent episodes of wheeze are they needing hospital stay? So some children will just get occasionally wheezy with a cough or cold, and that's absolutely fine. They can safely be managed at home with appropriate safety net advice and a wheeze plan. The children who are needing to come into hospital multiple times are probably a bit more important, and it's important to think about what is it that's triggering them. And it may not be that there is a serious underlying pathology, and it may be that they're moving on to develop a more asthma-type phenotype, but they certainly need to be considered in a bit more detail. Children, the main thing we always think about in children of this age is growth, because growth is a really important sign for kind of health and general development. So the children who are faltering in their growth or falling off their centiles, that's really important to think about. Clubbing, if you can see it, is definitely a red flag, and we'd certainly want to see any child that we felt had finger clubbing. And children with fixed crepitations, so that's kind of a more prolonged presentation. So that's they've been seen a number of times and they've got fixed focal signs. Children with a wet cough for 6 weeks persistently, and this can be really difficult to distinguish, and it's all about how you have to be really specific with the history and asking parents in detail about whether or not they've had a period of getting better, being relatively cough-free, and then developing another cough, or whether or not they are actually genuinely having the same illness that's persisted for greater than 6 weeks. Sorry, this isn't very big. But so if there are recurrent episodes, we know that some children, as I've said, may be starting to develop an asthma type phenotype, particularly in the slightly older ones. And it's important here that we consider the triggers. At this time of year, other than smoking, probably the biggest trigger is hay fever and pollen, and starting treatment with antihistamine can really impact on their health and support them and reduce their frequency of episodes. For the children who are kind of at that upper age limit of preschool wheeze, a trial of an inhaled corticosteroid of something like Clenil or a consideration of Montelukast would not be an unreasonable thing to do. It's really important, if you do consider a trial, that we're clear about what symptoms we're trying to improve, and that we keep a record of whether or not there is improvement in those symptoms. For the majority of children where you consider it worthwhile having a trial, it's probably to do with either the presence of interval symptoms, so either cough and wheeze during exercise, nocturnal cough, or recurrent episodes of wheeze, which don't seem to be completely always triggered by a viral illness. If you do start a trial, agreeing what the symptoms you're trying to improve at the start is important. You do the trial, and the duration of that we would recommend would usually be about 6 weeks. It may be longer if it's to do with recurrent episodes of wheeze, but then the ideal thing to do is to stop that treatment and review whether or not those symptoms that you considered and agreed at the start recur, because sometimes we know that these children simply grow out of their symptoms, and there's a large proportion of children who have recurrent viral induced wheeze as a small toddler who never have any other symptoms as they get older. So what we want to do is only have children who are getting recurrent symptoms on treatment, and that's why the break of treatment is really important. We would often do that break in the spring, summer, so that they've got the best chance of being well. And you may find that then by the following winter, they don't need any further treatment. If there's no response to that treatment, absolutely, we would be happy for those children to be referred, because the question is, one, is the diagnosis one of recurrent wheeze? or is this an alternative diagnosis? But in the community with the well children, it would not be unreasonable to consider a trial. Chronic cough plays into very nicely the recurrent wheeze, because actually often what you find, some children get just cough, some children get wheeze, and in some families and children it can be really difficult to distinguish between the two on history, and that's because people often mean different things when they talk about wheeze, and trying to delineate that and work out the difference can be really hard. Videos on phones can be a really powerful tool, and I often encourage families to do this for kind of difficulty with noisy breathing or cough and wheezy episodes. The commonest reason for having a chronic cough is still a recurrent viral infection, and that they've never quite got better, or that they've got better but then immediately picked up another viral infection. So trying to ask about that is really important, because what you want to know is it really a chronic cough or is it actually a recurrent cough? The other thing that we see really commonly is a post-viral cough. And for children who've had bronchiolitis, they may cough post their illness for up to a month, and that's very much normal. In school-age children, or just the kind of upper limit of this age presentation, you may get a post-viral cough for at least 14 days after they've recovered from the viral illness, but actually it can also persist for even longer, and even up to sort of 6 to 8 weeks. So that's the commonest reason that we find. Also, the thing that we think about, and the families that I'm sure we are all used to seeing, are those recurrent viral infections. And I have a lot of sympathy with parents who just say that their children are always ill, because when you break it down, that is the truth. If you think about the fact that the average child who goes to a nursery or a school setting may have sort of up to 7 or 10 viral infections in the year, they will often cluster in the winter. If you think about how long the average one lasts, and the fact that we're now saying they may cough for a couple of weeks after that, those children will be consistently unwell over that period of the winter in particular. And that's probably the commonest thing that we see for chronic cough. However, there are some children who will present in a similar way, but actually have a slightly more significant pathology underlying, and that's the group that we don't really want to miss. So those ones that we're thinking about are the persistent daily cough, the systemic features. So have they got weight loss? Have they got persistent fever? Have they got poor weight gain, even if not weight loss? And actually recording the weight is a really important thing. We try and record the weight at every presentation for children who come to the hospital. Our compliance is not 100%, and actually we've often been caught out, but it's a really powerful thing to weigh children, and ideally then plot them on an appropriate centile chart, because then, one, we can either reassure families that despite the fact that they are ill and that they feel that they're not necessarily eating very well, they may be gaining weight. And then if they're not gaining weight, it gives us really valuable information to think about whether or not we need to investigate further. Other things that are important are children who present with significant hemoptysis, and also children who present in very early on in life, or who are coughing with feeding. There are a cohort of children who struggle with their swallow, and that would typically be associated with coughing and spluttering with feeding. Again, it's not always immediately obvious to parents, and sometimes not even immediately obvious to professionals, but if you ask specifically, then sometimes this can come out in the history. And these are children that we would definitely want to see in the outpatient department. And depending on how the hospital is set up, it will depend on how quickly they're seen. So thinking about what those pathologies are that we're looking for, we're looking at things like early onset asthma, aspirated foreign body, or for the children who are struggling to coordinate their feeding and breathing, an unsafe swallow. Postnasal drip can also be a presentation, and actually gastroesophageal reflux, probably more in the younger age group, but can still be a part of it. More serious pathologies such as CF or TB or immunodeficiency can also present with respiratory illness. Remember that we screen for the commonest causes of CF in the UK, but that doesn't mean there won't be later presentations, but it does mean that it's much less likely. And any of these pathologies, we would expect to have one of those red flags on presentation, either on history or examination, and they're the things that we're trying to look for. So moving away from cough for a moment, we're going to have a think about some diarrhea and vomiting. Again, it's a really common presentation at this time of year, and those of you who came to the presentation last week, you'll recognise some of these slides. The important thing acutely is really to think about what the alternative diagnosis is, and I think that's probably the thing that gets most people concerned. Alternative diagnosis is usually thinking about the things that don't fit in with a typical pattern for viral gastroenteritis, which is the commonest cause of diarrhea and vomiting in children. Also, are they systemically unwell? So actually, is this a presentation of a more sepsis-like illness? Are they unwell? Do they look unwell? Do they look shut down? Do they have abnormal observations? Or have they got bilious vomiting? Or have they got a fever which you feel is disproportionate to their presentation with vomiting and diarrhea? The duration of symptoms is also important, and particularly with vomiting alone, that may make you think of an alternative diagnosis. Our professional pathway from Healthier Together hopefully pulls together some of these things and alerts you to when you should be slightly more concerned. And you can see that we've split it into the green, amber and the red, but the majority of children will fit into the green area for this professionals pathway. A few will be in the amber, and there's appropriate safety net advice that can be given, and the very few that fit into the red should obviously be referred. This is when the Healthier Together website can really support you if you use your professional pathway to support your decision making process, and then you can use the parent pages, which are just cut out and shown here, to share with parents how they can continue to manage the children. We always find that the most important thing to say to parents is that things may change, and that's why, whilst you might be in the green category now, sharing the information which has got the red, amber and green by the SMS text message, which is in the top corner of the Healthy Together website page, means that parents know what they're looking out for. When there have been criticisms of safety netting in the past, it's been about not being specific, and I think that's one of the great things about Healthy Together is it provides you with that specific safety net and information written in a way that parents will be able to understand and appreciate, so that they know what the signs are looking out for and that they have some support into whether or not they need to escalate their concerns about their child. Moving on to a little bit more about some slightly more outpatient or more chronic problems. Lymphadenopathy is an issue that we get multiple questions about most weeks, and I suspect this comes slightly from people who see adults and children. It's been a long time since I've seen any adults, so I certainly wouldn't be giving any advice about that, but my understanding is that lymphadenopathy in an adult is a much more concerning thing. What we see in children is that this is really common, and there are some children who, particularly if they're slim, you can feel their lymph nodes almost invariably for a couple of years. Lymph nodes tend to be much more persistent in children than in adults, and actually the most useful thing are the reassuring features. Most lymph nodes that are soft, that are mobile, that just kind of move under your fingers as you feel them, and are small, are reassuring and do not need anything further. There may well be an associated recent viral infection, but not always, and particularly children who have eczema or things like nits or anything that causes inflammation somewhere may be slightly more prone to having lymph nodes. These children do not need anything else doing. The ones that we think about, the ones that worry us, the ones that are just slightly more unusual, will tend to be lymph nodes which are larger than 2 centimeters and growing. And 2 centimeters is actually a really quite a decent size when you start feeling lots of children's necks for lymph nodes. They often have associated symptoms, and these again are slightly out of keeping with the more viral infections that you see. So they tend to have they may have things like weight loss, they may have things like prolonged fever, or they may have odd pains or aches and pains or itch. You may find on examination that you can actually feel a liver or a spleen, which again would be, in the context of feeling large lymph nodes, would be a concerning feature. Children can have lymph nodes everywhere. The places that we know are much more unusual with kind of unworrying disease is things like supraclavicular or popliteal. The presence of lymph nodes in those areas is more unusual and should warrant further input. Because this is such a common presentation, there is a really nice pathway, and actually people who refer lymph nodes to us at the Children's Hospital will often be sent this with advice explaining whether or not further information is needed, or in fact whether or not any further investigation is needed. This covers the majority of the things that I've just been through. In this setting, most children who have lymphadenopathy will fall into the green setting, and nothing else needs to be done other than reassurance. Some will fall into amber, and there's some advice there about what to do in those situations, and very few will fall into the red, but obviously those are the ones that we don't want to miss, and those are the red flags that we should be looking for. Probably the commonest presentation that we see in pediatrics as a whole, or certainly one of the commonest, is tummy ache. And I'm just going to think about this in both in acute presentations and then in the more chronic outpatient setting. So acutely, we know that the things we need to worry about are the acute abdomen. So these are often things that would be a surgical presentation and are concerns for the surgical team. Really important that we remember that the testicles are part of the abdominal system, and remember to examine those where they are present. The other things that are important to think about in the signs of red flags are not only the presence of signs suggesting a surgical abdomen, so bilious vomiting, significant blood, PR, or really quite severe pain, and particularly right-sided, but thinking about the more medical diagnoses that can mimic an acute abdomen. So thinking about diabetes, have they got polyuria, have they got polydipsia, have they got an abnormal blood sugar, and then also the things like pneumonia, which we know can present with tummy pain. And these are all in our red flags, and you can be guided by with regards to history and examination. The abdominal pain pathway just highlights this and explains what you should do. Depending on where you work will determine where you will refer your patients to. Many of the patients where there is questions about testicular pain will come to one of the bigger hospitals, and that's fine. But thinking about all the other things are also part of that pathway. Again, we have a parent page where you can safety net for the parents and give them the information again, so that you may be saying that your child doesn't need any further intervention at this time because they're falling very much into the green, and particularly as parents access healthcare earlier in an illness than they have done historically, sometimes it can be harder to make a diagnosis because the signs and the symptoms are not there. And this is when good safety netting with detailed and specifics really comes into its own. And we hope that that's what we've provided you with the parent pages for Healthier Together, so you can provide that information so that parents can feel well equipped to deal with the fact that their child may worsen before they get better, but so that they know where they can seek help. Chronic tummy pain is something that we get a lot of referrals for as an outpatient, and it is almost certainly, I would guess, the top of the list. The majority of the tummy pain that is referred to us, both and is seen in outpatients, is not significant pathology. And it will fall into, there are multiple different terms that people use: non-specific abdominal pain, for slightly older children, functional abdominal pain. But I guess the most important part of this is that it frequently does not have a significant pathology. So whilst it can be a cause of significant stress for children and their parents and their families, we know that the majority of children will not have significant problems underlying. In fact, frequently it's a diagnosis that non-specific abdominal pain is a diagnosis we should be making in a positive manner, because it does, like other things, have a really classical presentation. It is almost universally peri-umbilical or central. It's classically in children from about the age of 3, but you can certainly see it in the articulate younger ones. Children will be thriving, so they'll be growing nicely. There won't be concerns about their growth. There may be significant concerns about their eating and how picky they are, but it won't be affecting their growth. Non-specific abdominal pain can interrupt activities, so just because it's stopping them from playing doesn't mean it's not non-specific abdominal pain, and it can be recurrent, and it can also be persistent, or it can be more intermittent in nature. The red flags for children presenting with tummy pain are that they've had weight loss, if they've had melena or fresh blood in the absence of constipation, persistent diarrhea, which if it's genuinely persistent diarrhea will usually be associated with weight loss, or if the child's being woken from sleep by pain, or being woken from sleep to open their bowels. And again, that's something that needs to be specifically asked about. That would be more of a concern. Tests not to do. I think tests not to do is probably more important than tests to do. We know that in the adult population, certainly in older children, fecal calprotectin can be a really helpful test, including in a screening as a screening stool, a screening test. In this age group, it's really not helpful. Fecal calprotectin is often much higher in this age group, and there isn't good data as to know what's normal. We really don't recommend routine testing in this preschool age group with fecal calprotectin because it's not helpful. If you're concerned about an early onset inflammatory bowel disease, these children will almost universally have a true colitis picture with bloody diarrhea, weight loss, and often other systems involved, so often skin problems or a strong family history, and they will look very different. So the use of fecal calprotectin in this age group is something that we really wouldn't recommend. The same is true for H. pylori. We know that children can be asymptomatically colonised with this without any concerns, and we don't recommend the use of routine blanket testing unless there's a specific concern around H. pylori and gastritis. And actually, in this age group, I don't think they're able to be specific enough to be able to warrant H. pylori testing, so we would really not recommend using either of these tests. So most of the time you can make a diagnosis of functional or non-specific abdominal pain in this age group without the need for any tests. It's really important to think about whether or not there is a cause that should be treated, because sometimes there can be some underlying pathology, but as I said, it's rarely serious. Constipation is the most absolute common thing that we see in the outpatients, and I'm going to come on to another slide in a moment. If you feel blood tests are indicated, probably the only test that we would recommend would be to consider a diagnosis of celiac disease. Sometimes this can be apparent in the family history, or there can be a strong association with what the child's been eating if they've been having worse pain associated with gluten-containing products. The things to know about a celiac test are, if you're going to do it, the child needs to have had gluten in their diet for 6 weeks prior to the blood test, otherwise it's not really helpful. And it can be done as a blood test. If it is then negative, we would recommend reassuring the family and continuing a normal diet. The management of most tummy pain in children is reassurance, and I always explain to families that depends on what sort of a family they are. Sometimes acknowledging the pain and moving on can be the most important thing. Sometimes ignoring it and helping the child to do that can be really helpful. But from a medical perspective, the most important thing is to think about constipation. I can guarantee you that the majority of children that I've seen who have been significantly constipated have denied that they were constipated when I first saw them. If you look and ask for constipation, you will find it. They rarely present with the classical history of rabbit dropping stools, but if you ask about constipation, you will find it. Children who are presenting with soiling are constipated until proven otherwise. Children who have recurrent urinary tract infections, or in fact, much more typically, recurrent urinary symptoms are usually constipated. And a lot of the children that we see who are constipated have a presentation of loose stool or diarrhea. And they may also have non-specific abdominal pain, which is why it's so important to ask about constipation. We have a nice constipation pathway which highlights some of these and explains what the red flags are and when to think about other diagnoses. I'll come on to the red flags in a couple of slides. It also gives you the nice guidelines for disimpaction in the amber zone and the simple measures and some links in the green zone. The common pitfalls, and these are things that I've learned the hard way for treating constipation, are not treating for long enough. Often this is a constipation will have been developing over a period of a few months, and therefore it's worth explaining to families that actually it will often take a reasonable amount of time to get good control and get things back to normal. Parents often worry rightly about having their children on medications for a long time, but I always explain that the medications we use to treat constipation are firstly very safe, and secondly it's better to treat it completely and then you are likely to remain off medication for longer than to do a kind of start-stop situation. The other thing we notice is that Movicol is a great drug, but sometimes not adding a stimulant such as sodium picosulfate results in not completely improving the symptoms, and that is listed in the NICE guidance. Children really struggle to tolerate laxatives, and I used to be really unsympathetic towards this, and it's one of the rare situations where as I've got older, I've actually got much more sympathetic. I think asking children to take a lot of Movicol is tricky, and whatever the manufacturers state, you can absolutely taste it, whatever you mix it in. I swear that if you put 20 glasses out and put Movicol in 3 of them, your average toddler could pick them out, probably just by smell. The best laxative is the one that the child will take, and this often takes a bit of trial and error. The BNFC actually gives you disimpaction programs for lactulose alongside sodium picosulfate, and finding a medication that the children can reliably take is probably the most important thing. The other common pitfall we see is that children will, because they often present to the emergency department as their first port of call, they will often get a disimpaction program, which is great. That's often what they need to really get things started, but they then need maintenance treatment. And I think that's probably another one of the biggest pitfalls, is that they get disimpacted, no one maintains them on some maintenance treatment, their symptoms occur, and then they require further disimpaction, and you've sort of lost the parents by that point. So using maintenance treatment can be really helpful and can maintain children being well. The red flags that we think about are constipation from an early age, with also the concern about not passing meconium in the first 48 hours of life. Obviously, things such as weakness in the legs or concerns about walking if they're not ambulant yet. Abdominal distension that is out of keeping with simple constipation, or an anus that looks abnormal. We don't advocate PRing, but we do recommend that someone looks at their bottom. An abnormal examination of the spine, or abnormal neuromuscular or reflexes. And then the other red flag is persistent constipation despite maximal doses of laxatives. And this should be a red flag on a number of levels. Often this is because they're picking up the medicine, but they're not able to get the toddler to take it. So that's when discussing the family and having an open discussion about what they can take, what they can't take, how they're managing can be really helpful. But if they're genuinely on high doses of laxatives and they're not opening their bowels, this is either not constipation or there's something else going on as well. But having that discussion with the family is really important. The Healthy Together website support has a lot of information about constipation, and this is just a snapshot of what the parent information page looks like. There's information under each of those banners, and there's also some videos to watch. There are links to the ERIC website, which again is a really helpful website to support families, and I think it also supports children, so probably in the slightly older group than we're talking about, there's also information available for children so that they can understand and we can get them on board. Very much linked into constipation is urinary tract infection. This is something that's a particular interest in the Northeast. We have done a lot of research within the Northeast around urinary tract infection and around trying to prevent it. The important things about urinary tract infections are, again, coming down to how do you collect the sample. Recently at the Children's Hospital, we have gone back to trying to only get clean catch samples. Now, this can be frustrating for families, but what is more frustrating is having a contaminated urine and not being able to give them an answer either way. So personally, my feeling is if you need a urine sample because you think the clinical picture fits with urinary tract infection, getting the correct urine in the right way will really help with that, particularly when now we're going to think about whether or not they need further investigation. I think the recommendation of having nappy off, following them with a pot is probably the best thing, and it's important to explain to parents why you're doing that. Thinking about an alternative diagnosis as well, so is there another reason for their symptoms? And as I suggested with the constipation, you can almost diagnose constipation from a microbiology chart, because these children will have had 20 or 30 urine samples sent with either no growth or mixed growth or contaminant growth. And that's because they're getting dysuria or symptoms because of their constipation and not because of a UTI. So in children who either present with recurrent UTI or recurrent urinary symptoms, treating constipation can be life-changing and reduce the amount of antibiotics they need. We follow the NICE guidelines for the acute management of UTI, and the age group that we obviously are particularly concerned about are the small babies, the babies of less than 3 months, where they may have spread of the bacteria from urine into blood or even into CSF. And this just gives you some guidance about what to do and who to think about and how to escalate those acute concerns. Following the acute management of a UTI, we continue to follow the NICE guidelines for management following a UTI. And this results in far fewer children than previously requiring investigations. This chart sets out quite nicely who needs investigations and when, and it also draws your attention to the fact that historically we've given quite a lot of prophylactic antibiotics, whereas now this is something that we've moved away from, which I think is overall positive. And we're also doing far fewer investigations. The last thing I was just going to talk about is sleep. And the reason I talk about it is that actually it's something that we get a lot of requests for and a common referral. We don't see primary sleep problems in outpatients. It's not part of our remit. Increasingly, I can see that the referrals seem to be going up, both from a young age and in the older children. And we are very empathic and see the impact that poor sleep has on children. But unfortunately, it's not something we can offer a service for. However, because of the number of children referred, we have actually put quite a lot of effort into the resources that we provide on Healthier Together and the resources that we will share with parents and families. The things that it is worth thinking about are there any factors that are there any medical factors that are contributing to these symptoms? So thinking about have they got nocturnal cough? Are they snoring? And if they're snoring quite significantly every night, even when they're well, do they have large tonsils, and would they warrant a referral to the ear, nose and throat team? Things like night terrors and sleepwalking can obviously also contribute to poor sleep, and there's a lot of information about those things on the NHS website, and that's a great resource as well. We also have, and this was created by one of my colleagues who has a real interest in sleep, a whole section about healthy sleep and some tips for parents and for children as they get older. We know that the most important thing for sleep for all age groups and for adults and for ourselves is to think about sleep hygiene. We also know that it's really difficult to be consistent, and that's the commonest thing that we find is that families are able to do it in a short period of time, but it takes a lot of emotional and resilience and strength to persist with the boundaries and the settings, and particularly with the slightly older children who spend more time on screens. But we know that it's the thing that will contribute most to sleep. There are some top tips for sleep here, which I've just copied onto here for the preschool age group, but within the Healthy Together website, for those of you who work with children of all ages, there is a section for each one. And again, this is written for both professionals and for parents. There's also information about sleep in hospitals, so anyone who has families where the children spend a reasonable amount of time in hospital, there's also some information for sleep in hospitals. And there's also some tips for adults, for those of us who are perhaps not so good at following our own advice and using screens late into the night. So that is all I was going to say, but I'm quite happy to take any questions, either hands up, or if you want to pop them in the chat, and myself and Laura will keep an eye out on the chat.
Thank you, Alex. Does anybody have any questions? This is where we all go
quiet. This is where it goes silent.
I know.
What question?
Has somebody got one there?
No, they have fluid, don't they?
No.
Nope.
Anybody, if you want to put them in the chat, anything that has this been, of relevance? Is there things that you'd like us to cover? For future sessions that we could have covered? No, thank you. Very helpful and useful. So someone's just put a question: is blood in stool in a well child of any concern?
So I think the most common cause of blood in stool is constipation, and I would treat that in the first instance, and that will usually stop the symptom.
Yep. Anybody else?
So Rashes and skin infections is a recurring theme, so it's on my list to try and sort a session out for that. I might be able to find someone better placed than I, but if not, I shall pull something together.
Thanks. We've just got lots of thank yous, people saying it's very informative. So we've got a bit of a mix as well of people here, so that's good. It's good to know that we're obviously pitching the sessions at the right level. We will be looking to arrange some future ones coming soon and look at the topics that we've had people recommend, so that'd be good.
Brilliant.
So,
And feel free to
yeah.
drop us some emails if you want to give feedback kind of outside of the chat.
Thank you, and we will upload the session as well onto Healthier Together and share the link with everybody who is either registered or attended, because I know sometimes people obviously can't attend, so we do try to put them uploaded as quickly as we can, and then people have got access to them. Okay, thank you very much, everybody.
Thanks, Laura. Bye.
Bye.